Good morning, everybody. Can you hear me? Great. Well, this is wonderful. Thank you so much for coming. If you folks didn't come to participate in this, it wouldn't be a success, and this is just great to see you here. I just really want to emphasize that this day is for you. If you're a person who's been diagnosed with PMP or appendiceal cancer, or someone you know has been diagnosed with it, this is an opportunity for you to look around and meet some other people who are also dealing with this issue, and like Jim said, realize that you're not alone. There really are people, as rare as it is, there definitely are other people that are struggling with the issues that come with this problem, and we want you to feel supported, and we want you to know that we're here for you, that we have an interest in this disease, and we're trying to make improvements in treating it and hopefully preventing it and identifying the cause of it. A couple of logistical points before we get started. The restrooms are over to your left over there. Luigi has asked, who's doing our videotaping, has asked if people could actually turn their cell phones off because he feels that could actually really interfere with the videotaping while we're doing this. Again, I want to just thank everybody for coming. This is our second annual PMP research symposium. And before I get started, I just want to say some thank yous as well. I want to thank Jerry Lewandowski and Jim Carroll and Judy Culbertson from the PMP Research Foundation, because without their support, we simply couldn't have this symposium. I also want to thank Dora Halleck as well. Dora is really the person who just puts these symposiums all together. Without her, it just couldn't have come together. I want to thank Susan Prunier, who's one of our administrative assistants in the Division of Surgical Oncology. She also was just super helpful in getting all the logistics done. And Pam Devaney, who really helped us with getting the word out and the publications and the agenda that you see. A lot of these slides may look familiar if you came last year. I did take a lot of the slides from my last presentation, but for those of you who didn't get to hear the presentation last year, I kind of think of pseudomyxoma and appendiceal cancer as the perfect storm. And this is a picture from that movie. And the reason why I think of that is because tumors of the appendix or cancers of the appendix are rare tumors. I think anybody who's been diagnosed with this and has probably, with their first encounter with whoever gave them the diagnosis, probably didn't get a lot of information, didn't feel like the person really had ever maybe seen this before. You go online and you start seeing the word rare, and you realize that this is just not something that's common and people just don't know very much about it. In addition, there's a really unique anatomy of the appendix. When I'm talking to people that come to me, I explain to them that the appendix is normally about the size of your little finger, and it's like a little balloon that hangs off the colon, and it has a very, very thin wall. And so for that reason, it's very easy for a tumor or cancer to break through that appendix and get outside the appendix and then spread around the belly cavity. So unlike other cancers that in order to spread, the cells have to escape and maybe get into the bloodstream or the lymph system and spread to other parts of the body, the appendix has this ability or the tumors in the appendix have this ability to break through the wall of the appendix and immediately have access to the belly cavity. So that creates a whole unique set of issues for these types of tumors. And then there's the unique biology of these cells. The cells that cause cancers or tumors of the appendix are the cells that line the inside of the appendix, and their job is to make this substance that we call mucin. And mucin is kind of this gelatinous, viscous fluid that normally just comes into the inside of the appendix and then goes into the inside of the colon and mixes with stool and kind of comes out the other end, and we never think about it, it's just there. But when it gets into the belly cavity, and when those cells that make that mucin get into the belly cavity and they keep making that mucin, over time that becomes a problem. That mucin builds up, it takes up space, it causes bowel blockages. And so that also is another unique aspect of this disease. And then the other thing that really makes this the perfect storm is that once you're diagnosed with this and you've been told that the cancer or the tumor has gotten out of the appendix and it's in the belly cavity, And you go online or you meet a surgical oncologist who treats this, and they start talking about this treatment called cytoreductive surgery and hyperthermic intraperitoneal chemotherapy, or HIPEC. You know, you're talking about one of the most daunting treatments that we offer people, a major abdominal surgery that can take 8 to 12 to 17 hours if that's what it takes. And at the same time, we're going to pour heated chemotherapy in the belly cavity and try to kill any cells and make sure it doesn't come back. I mean, that's, you know, here you've got this rare diagnosis with this weird biology that causes this stuff that nobody's ever heard of, and you want me to do what to treat it? It really is the perfect storm of diseases. Just to review a little bit, I kind of mentioned this, but again, this is what the appendix looks like. It hangs off the right colon, the very beginning part of the right colon. If this is the person's head up here and the feet are down here, this is the right lower quadrant of the belly cavity. And again, the appendix is this little finger-like projection that comes off the very first part of the colon. And normally it looks like this, very thin and narrow. And again, this just shows you that the location of the appendix is right around here. And the other thing that we talk about is the peritoneal cavity. So if you can imagine, all of the contents within your abdomen are contained within a sac, actually. And this sac literally looks like saran wrap. It has integrity. You can actually remove it at the time of surgery. You can peel it off of the inside of the abdominal cavity. And this is sort of it outlined here in red. And this is called the peritoneum. So those are just some terms for you to be familiar with as you're hearing some of the lectures that are coming up through the rest of the symposium. Again, as we mentioned, these mucinous tumors and cancers of the appendix are considered extremely rare, with an estimated 1,000 to 1,500 cases per year in the United States. I'm going to show you some data that we've gathered here at UMass and that another group has looked at. We really think that the is larger than is reported. It certainly seems like we're seeing more people that are diagnosed with it. I suspect Dr. Pingpank is seeing the same at Pennsylvania. And we don't know whether we're just recognizing it now or whether the incidence really is increasing. But it certainly seems it's not this rare, even though this is what's reported in the literature. It arises from those cells that line the appendix called goblet cells. And those goblet cells, that's the pathologic name for how they look under the microscope. They produce this gelatinous, mucinous, jelly-like substance that we call mucin. So we talked a little bit about it, but what happens when a mucin-producing tumor grows in a thin-wall balloon-like structure such as the appendix? And I put up a little advanced warning. There are going to be some for people with mucinous tumors, and that's an area of great interest, especially if people are looking at having multiple scans in young people for the rest of their lives and the concern about radiation with CT scans. Most people will need to go on to either have a biopsy or surgery to remove the appendix, and then the specimen and the biopsy are sent to the pathologist where they look under the microscope and they try to tell us more about the tumor. What does it look like under the microscope? We've talked before about the spectrum of the pathology that can present from very low-grade or almost benign-looking cells that make this mucinous ascites to more aggressive types of cancers, the poorly differentiated, the signet ring cells that tend to be a little bit more aggressive. And that's really important because it determines how we're going to treat a person. And we have Dr. Switzer with us today, who's one of our new medical oncologists, who's specifically focusing on appendiceal cancer, and he's joining our other medical oncologist, Dr. Bethini, to help take care of people in a multidisciplinary approach. And we're going to have one of our pathologists come and talk to us later in the program as well and show you some slides of how this looks under the microscope and what are the things that they're looking for to help us guide treatment for people with this problem. And then the other thing we look at are tumor markers. Those are proteins that we can measure in the blood that are specifically made by the tumor cells, and they help us to monitor people so that if the tumor markers are elevated or abnormal and then a person has treatment, we can follow those by just looking at those blood tests and see if the treatment we're doing seems to be working, or if the person is off treatment and we're just monitoring them. If those tumor markers start to go up, it might mean a sign that the tumor's coming back and we need to look into where is it and what should we do at that point. So the treatment for this is really what we call a multidisciplinary approach. It's not just surgery. I know you go online and you see surgery and the heated chemotherapy, but it's really so much more than that, because we're recognizing that the spectrum of the disease is so important. It determines what type of treatment we want to do for the person to get the best outcome. So it involves surgery a lot of times, but it also involves intravenous chemotherapy and working with our medical oncologists. And it really is driven by the pathology. So having a pathologist who is really dedicated to really understanding the tumors and knowing the different terminology and what we're looking for to help guide that. And it also depends on the location and the stage, how the person presents, how much tumor is there, where is it located. All this has to come together to determine how we're going to best help somebody that has this problem. So I'd like to share with you some experience that we've had here at UMass. We went back to look at just, the people that are coming to see us for this problem. What is it that they need? How are they presenting? How are they getting to us? How can we better help them? And we presented this, one of our chief residents, Erica Schneider, presented this paper at a colorectal conference looking at mucinous neoplasms of the appendix. And we call it a plea for early referral to a high-volume center. Because of the unique nature and all the unusual issues with this tumor, and because of the rarity of it, we really think that the earlier somebody gets to a high-volume center, the better their care is going to be, the better their satisfaction is going to be, because they're just going to feel like, I found somebody that has actually seen what I'm dealing with here. So between 2009 and 2011, we had 82 patients that came with appendiceal tumors of some variety. Most patients were coming to us for initial treatment options, which was great. 60% of those patients were coming to us for initial treatment options. 30% had already been previously treated and were coming to see, what should I do now? And 10% were coming because they'd really been treated pretty much completely, and they were looking for help with symptom control and goals of care at the time that they presented. Most patients were referred by other surgeons, but what's astounding is that 34% of people found us on their own. And I think that's a real issue, and that's one of the major goals and agendas of this symposium, is to get the word out, not just for people who are dealing with the disease themselves, but get the word out to surgeons and gynecologists and medical oncologists, so that when they see this disease, they will recognize it and recognize that there are people who specialize in it and that there is a whole treatment plan that comes with it. The next group was medical referrals, and then remarkably, we actually had 3 people who were diagnosed because they came in through the emergency room or were in the hospital, and somebody recognized what they had, and I was fortunate that they were able to call me and let me know about the person being here. Of the surgeons who made the referrals, the most were general surgeons, which is great, surgical oncologists, and then the gynecologic oncologists after that. Most patients that come to us are from the state of Massachusetts, but a good portion, 35%, come from out of state. Again, it being so rare and there's so few centers that people really do, unfortunately, have to travel for this, and we had 4 patients that were international. Of the patients that we had, 34% were male, which is a little bit different than what's reported in the literature and what my experience was down at the MD Anderson Cancer Center. It's usually more 50-50. Again, the average age for us was 52, and most people presented with what we call stage 4 disease. Now, stage 4 disease, I know when people go on, they talk about stages, stage 4 being the highest stage, and everybody gets concerned about that, appropriately so. But really, stage 4, most people with appendiceal tumors, again, because that appendix is so flimsy and those cells can so easily get out of the appendix, most people are going to present with what we call stage 4 disease because the cancer has gotten out of the appendix. But it's not necessarily because the cancer is so aggressive that it spread through the bloodstream and spread to other parts of the body. You could have a very low-grade tumor, but it has broken through the appendix, and now you have stage 4. So there's stage 4, and then there's stage 4, so it can be very different. The most common presenting sign was right lower quadrant pain, and then the next one was that increasing abdominal girth. A lot of people just presented with an incidental findings and then appendicitis, and then there were some other symptoms as well. Most patients had undergone at least 1 surgery before coming to us, and on average it was 1.3. But one person had actually had 10 surgeries before they got to us. And so we see that commonly with this problem. 6 patients had had a previous heated intraperitoneal chemotherapy, and about a third had had prior chemotherapy before coming to us. The most common pathology that we see is those low-grade tumors, either a mucinous cystadenoma, and I know Dr. Walter will talk to you about this. That's actually a benign tumor. It's technically not a cancer, and yet it has its own set of issues. It can be a life-threatening problem if it gets into the belly cavity and makes pseudomyxoma. And we tried to look and see, how did people really miss an opportunity by not getting to us in a timely fashion? Fortunately, it seemed like most of the people that we saw got to us what we would call a timely fashion, 72%, but there were about almost 30% of patients who didn't get to us in what we considered a timely fashion. And we felt that about 6 of these patients probably missed an opportunity for a therapeutic heated intraperitoneal chemotherapy. More people, we also felt that about 4 people at the time of HIPEC, were able to do the HIPEC for them, but their disease was much more advanced than it probably would have been, looking back through their record and trying to sort that out. We felt that a couple people had some unnecessary surgeries, and some people had delay in controlling their symptoms. And one person was very, very upset about unnecessary clinic visits and expenses because he'd been sent to somebody who knew nothing about this disease and had to travel for that. So again, it's that concept of just getting a person to a place where somebody knows what they're dealing with. We did think that there were probably we also wanted to see if there were people who would not have benefited if they had gotten to us earlier. And we felt that there were about 6 people that was probably the case, and most of those people had very advanced, very high-grade disease at the time of presentation, and at the other end of the spectrum was people with very indolent disease, so probably getting to us a little sooner might not have really made a difference for them, or unless, the importance of, again, being in a place where you feel comfortable, somebody knows the disease and can really give you confidence in the treatment that they're proposing. So just to summarize, these mucinous tumors of the appendix are rare, but they are also very diverse, and they have these unique clinical issues. People present with an array of treatment needs, including just surveillance. Things are really good. The tumor was removed. There didn't seem to be any spread of the tumor. We're just going to keep an eye on things. To needing surgery and either the heated chemotherapy or intravenous chemotherapy, or we're at a point where we're talking about controlling symptoms and improving quality of life and maximizing quality of life and longevity as best we can. And more than a third of people end up referring themselves to programs like this. We think that early professional referral to a high-volume center will optimize management and satisfaction, and equally important, it's going to improve our ability to understand, to study, to prevent, and cure this disease. So that's another important reason. We had a very successful year in our research program here. This is a presentation that one of our residents, Matt Furman, made at the Regional Therapies meeting, looking at the incidence of neoplasms in appendectomies. We looked back at our experience here in the last 5 years. We did over almost 400 appendectomies, and we actually found that 3.7% of those appendectomies, there was a tumor involved in them. 3.7%, that's at one institution over 5 years. That's not 1,000 a year across the United States. That's much, much higher than that. So there's another study that came out of Arizona in the past year as well, and they had very similar incidence rates. It's definitely higher than what has been reported. What was interesting was that sometimes when people present with appendicitis, you get a CAT scan and it looks like the appendix has already burst, and a lot of times surgeons will say, the safest thing to do is to give this person some antibiotics for about 6 weeks, and then we'll come back and take out the appendix. What we found was that in people that had that mode of treatment, 30% of those people had a tumor associated with that. So a lot of people that we see, they have that story. I had appendicitis, and they put me on antibiotics for 6 weeks, and then they went and took out the appendix, and they found it. And there are some surgeons who feel like if you do that and the patient gets better and their appendicitis resolves, then do we really need to take out the appendix? Well, based on our data, we really think the appendix needs to come out if that's the way it's going to be treated. We also looked at some of the physics of the heated intraperitoneal chemotherapy, and I hope you'll have a chance to go see the pump that has been brought over by Alan Doobie, one of our perfusionists, so people can see what it looks like. And what we've been looking at is whether or not the rate of flow that we circulate the heated chemotherapy at can improve the heating of the belly cavity and hopefully improve the treating of the cancer. And it seems that it does. The higher flow rates that you do, the better the heating is in the belly cavity, and so that's something that we're actively pursuing here at UMass, trying to just improve the efficacy of this treatment. We've also been looking at ways of making cancer cells more sensitive to chemotherapy and hyperthermia, and we've been using some drugs that specifically block what we call the cell cycle of cancer cells. Cancer cells have an unregulated cell cycle, so they are more sensitive to blocking their cell cycle, and if you can block their cell cycle, you can make them more sensitive to chemotherapy and hyperthermia. So it's been a pretty exciting year. I just want to acknowledge some of the people that are on the team here that make this program successful. As I mentioned, we have 2 medical oncologists now, Dr. Venu Bathini and Dr. Switzer, who just joined us after finishing his fellowship, who has a specific interest in appendiceal cancer. I cannot thank the nurses enough from the operating room, from the 3 ICU, but hugely and specifically for the nurses on 7 East. So anybody who's been on 7 East knows the quality of the nursing care that is provided there. They are phenomenal. Dr. Mikowski, who us from the palliative care perspective, Dr. Walter, who's really taken on the role of the primary pathologist for our mucinous tumors, Mark Wanta, who's and all the perfusionists, Dr. Kim, who specifically helps us with using MRI to look at for pseudomyxoma, and Dr. Mary Sullivan, who without whom I just couldn't do this at all. So she is a wealth of knowledge and just takes such excellent care of our patients. And again, I just want to remind everybody, you are not alone. We have people like Jim and Jerry and Judy who are pushing forward to find a cure for this. Gabriella Graham, who many of you know through the PMP Pals website. There are a number of other websites, including Dr. Esquivel's American Society of Peritoneal Surface Malignancy. So there's lots of resources, and we're always here as well. So we have a long way to go, but there is some light at the end on the horizon, I think. Thank you.